Well, yes, I'm Joost, and I'm an engineer, as already said, trained in Eindhoven, University of Technology in Eindhoven. I'm a biomedical engineer, but since 2004, 5, I already am in Maastricht, and Maastricht is not a technical environment at all. It's really a life sciences environment, so that also shaped me as an engineer, let's say. It kind of forced me to change my language mostly. So we will talk today a lot about physiology. Also, by the way, I don't mind to be interrupted. So if there is questions along the way, I think it's best to just ask them as if I were there in the room, and just let me know as soon as there is a question, because that can make the lecture maybe also a bit more interactive. Well, as already said, I have been in Bordeaux for my postdoc. It was actually just before the Lyric Institute existed. I think in the year I was there, I was very lucky because they got the final approval that they would get the money. So that was a very nice party, by the way. I could attend at the Smithsonian Lafitte. I will never forget that evening. Well, you know, I worked there a year long with people Mark knows very well as well.
Wine castle.
Yeah, it's a wine castle indeed. Yeah, so I worked with Pierre Borachard, Sylvain Ploux, Philippe Ritter, to dive into the mechanics of left bundle branch block and pacemaker therapy in general. And that's what I want to talk about today as well. So I hope I'm not too basic at certain points, but let's first start with the essentials. And that is a conduction disturbance called left bundle branch block. And I'm sure most of you know exactly what that is. The bottom line here is that due to a conduction problem, either a break in the cable of the bundle branch, but it can also be more distal disease of the Purkinje system. There is a clear delay of activation, of electrical activation, of the left ventricular free wall, the lateral wall, compared to the septum and the right ventricular free wall. And obviously in patients, this can have an endless variation of delays, but on average, those patients are characterized by a right to left electrical activation. As you know, is that in the normal heart, the ventricles are simulated or are activated rather synchronously. And that leads also to a pump function where all the myocardial walls act together and are creating the pump function more in harmony than in the left bundle branch block case. Well, there is also a therapy for this, where the Bordeaux group did a lot of research in and still is doing. This is called cardiac resynchronization therapy, where you basically sense the activation intrinsically from the sinus node in the atria, and then given a programmed delay, you stimulate the ventricles at two sites with a right ventricular lead and a left ventricular lead, with the aim to resynchronize the electrical activation of the two sides of the heart. Well, you may also know, I don't know if you already had a lecture about more physiological pacing at this point, not yet, but maybe that does have a place in the curriculum. But nowadays, people are pacing also the fast conducting system itself, in the hope that you can actually use that fast conducting system and maybe even pace with one lead. But when there is a break in the cable, that doesn't work, of course. So that's what now people have invested across the world, many groups have invested to see what determines the success or the absence of success of this therapy. And many factors have been identified to play a role and to modulate the outcome after applying this therapy. And obviously, it's very important to understand this, because, you know, a pacemaker is not like a pill. You don't give it today and stop tomorrow. It's something you implant, and if it's there, you can extract it. And also the Bordeaux group is very good at that. I know that, but you know, it's not something you wish to undergo as a patient, of course. So the question really is, who has a high potential for responding, really improving outcome, and who does not? Well, that's exactly the question we try to address with a model. And a model, in short, is a description of the physiology, the dynamic behavior of the cardiac physiology, using the physics laws that we know, and also the physiology maybe at the cellular level that is very crucial to the function of the heart. Then you try to put this in equations, in mathematical equations that describe this physiology and this physics, and you put that in programming language, and then you might end up, and this is work that took 30 years in Maastricht, so that's not a development that was entirely done under my supervision. It already started 30 years ago. And we end up with a model that is able to cross the bridge from membrane potential at the cellular level all the way to blood flow through valves and the vascular system in the cardiovascular system. Of course, this needs many layers of validation and so on, and I will not talk about that today. There is a lot of literature also being summarized at our website, which is www.circadapt.org. I will show you later. That is important. The typical thing, and that is really the result of us as engineers being in a non-engineering environment, is that always the physiology is leading in our environment. So as soon as when I came here as a student and I was presenting some simulations, and when the simulation of for example, a pressure curve doesn't look like a real pressure curve, then you lose your audience. So at a very detailed level, we always received a lot of feedback on the how real or not real our physiology looks like. And in that way, going into that conversation with physiologists, and one of the mentors of both of Mark and myself is Fritz Brinson, for example. He really added a lot of physiology to this model, and that we profit from on a daily basis at this moment. So it should be clear that this model is a simplification of reality. So there are lots of questions that you may encounter during your career that we cannot answer or address with this model, but there is still a lot we can investigate. And that really depends on the level of complexity. If you make a model very complex, you may be able to describe the physiology at a microscopic level, but bear in mind that the measurement options at that level are not as good as we in vivo, as we can do at the pump level. We can measure pressures and volumes. So it's a tricky balance between model complexity and uncertainty of the predictions of a model. So we aim, of course, for a maximum validity with minimum complexity. And that is what takes a lot of time and a lot of research. So that's in general. The modeling results that I will show you today will not be about the cellular level. We do have models, and also in Bordeaux, there is a very modeling group on cellular and tissue level. But what I want to show you today is mostly from force to pressure to blood flow, and that is the mechanics and hemodynamics of the heart. Okay, so this is the website, and I think I will more or less skip this slide, but really this model, and I will show you, allows you to simulate beat to beat the hemodynamics in terms of flows, volumes, pressures, but also the regional mechanics of the tissue. And nowadays, you may know, we can image this with echo or MRI, and even with CT nowadays, modeling groups manage to extract strain from CT images. And that gives you an idea how the model shortens and lengthens during the cardiac cycle. And that's very important in the left bundle branch block heart. I will show you now. So this is an example of part of the output created by our circuit up model. So on the left side, we see the more macroscopic hemodynamics. So that's pressure, volume. I'm sure everyone recognizes this pressure volume loops. Some medical students have nightmares about that. I know that because I'm teaching this to medical students, and it's not always an easy concept. There is flows across valves, and we have both the left and the right side of the heart in our model, and they interact through the interventricular septum. So here we see what the tissue feels, what, for example, a cell feels. So this is myofiber stress at the tissue level, and shortening here and lengthening during a cardiac cycle. So this looks like a volume curve you see here, but this is at the tissue level. You see here the left ventricular free wall in black and the septum in red, that during the isovolumic phases, of course, there is no shortening of the tissue or lengthening, and that there is shortening during the ejection phase, and then there is no deformation during the isovolumic relaxation phase. And then we have lengthening in two phases, which is the filling, the E and the A wave, during diastole. We can also extract a kind of a M mode. I don't know if you're familiar with that, but that is used with echo as well to visualize the motion of the walls in the heart. Also, if you plot stress and strain against each other here, you get nice loops. And the area of this loop gives you a good idea how the work is distributed in the heart. And I'll get back to that. So the unique thing here is really that it relates the mechanics at the tissue level to the hemodynamics, pump mechanics at the organ level. And we use a law that probably all of you have heard about, but we use conservation of energy of that. So the model fulfills that conservation of energy assumption, which for us is very important. Okay, so let's now do a very small simulation exercise. So if we think about left bundle branch block, I started to say that the left ventricular free wall is delayed in its electrical activation. So most likely also the mechanical activation is delayed. So if we prescribe in this mechanical model the moment at which the walls are going to build up force, tension, by cross-bridge formation in the myocytes, we can actually control that in this model and say that this left ventricular free wall here is actually delayed compared to the red wall, the septum, and also the right ventricular free wall. So if we do that in steps of 10 milliseconds, this is what we get. So between here and here, you see I'm alternating between synchronous and 10 milliseconds delay. We see already some minor changes at the tissue level. Also at the hemodynamics level, there is not a huge difference. But if we move on, we see that by changing a property, oh, that's too early, by changing a property of this wall, the mechanical behavior of the septum, which we didn't change anything about, completely changes. So why would that be? I don't know if someone can, answer that question. Why would the septum change its behavior if the left ventricular free wall has been changed in terms of its properties?
Ambroise, I'm sure you have the answer.
Maybe because of the interdependence between the two ventricles?
Yeah. So in the heart, if you consider this indeed as two cells, then if both cells simultaneously contract and lengthen, they operate under the same loading conditions. But if you guys would hold each other's hands and one starts pulling and the other doesn't, then one is being stretched and the other is contracting. And the one who is contracting actually feels less resistance because the one who is not contracting, not pulling, is actually being stretched. It's very easy to deform that person's arms, right? So this all has to do with pre and afterload. At the moment that the septum starts to be activated here and the free wall not, you see that the septum can easily contract. It goes down, while the free wall...
I'm sorry, Joost, but we do not see your pointer. If you're using a pointer on the slide, we do not see it.
Sorry for that. Good that you say that. Now you see it. So this is the moment where the septum is being mechanically activated and it starts shortening. At the same moment, its neighbor, the left ventricular free wall, is not activated yet, so it's being stretched. That's what you see here. A little while later, 50 milliseconds here, that's when the LV free wall gets activated as well, but because it's pre-stretched, it develops more force. How comes? Who knows that? How comes that a pre-stretched myocardium develops more force than the septum here?
The famous law we talked about.
Starling law?
Yes.
Starling law?
Yeah. So this is the Frank-Starling level at the tissue level. So you pre-stretch one wall, and thereby it starts developing more force. And at the other hand, this wall here starts actually shortening, but it doesn't lead to ejection because it can easily stretch the neighbor. So this, you can imagine, is a very inefficient situation. During the isovolumic phase, no change of volume, there is one half of the heart which is shortening and one half of the heart that is being stretched. And a bit later, that early activated wall here, the septum, is even being stretched during the ejection phase because it's less forceful. It's because one is developing a lot more force than the other. So that's how you can explain this quite complex change in mechanical behavior. And remember that we changed only one property of the heart, and that's the moment of activation of the lateral wall. If you then plot stress and strain against each other, you see that the black wall here, the lateral wall, increased in area, and I'm going back just to show you, and back to the largest delay, while the red wall actually decreased its area, and it even becomes a figure 8, and this is what one can count as negative work. So the late activated part of the left ventricle starts working much harder, whereas the early activated part of the heart actually decreased in its load and its work. So a group in Maastricht with Frits Benson and Kevin Van Nooy also showed later that this is also observed in dogs, and those dogs, they ablated the left ventricular, well, the left bundle branch, so they can acutely see how the mechanics of both walls respond to that change in activation sequence. And here you clearly see that compared to baseline here, synchronous heart, we have less shortening in the septum, here, the white bar, and that's exactly what we see here, and even more than normal shortening in the late activated wall. That's exactly what our model predicts. Same holds for the external work. You see that it becomes even 0 or negative. That's exactly what we see here in our loop. And we see an increase in work compared to the baseline in the late activated wall. And then also they did some myocardial blood flow measurements. So this is coronary perfusion. And also there you see a difference occurring. So this seemingly very simple abnormality in electrical activation has massive mechanical consequences. And this is also being reproduced in experiments in Oslo. Okay, this I already asked you. So the answer to this question is this Frank-Starling mechanism, which we know from experiments from the 70s, 80s, 90s. A lot of good physiology research has been done at that moment. And this is properties that we have in our equations. If we would not include this physiological behavior in our model equations, it would also not behave like this. Okay, so why do I think that tissue mechanics is really important for how we deal with patients? Or I don't deal with patients, but how the clinicians deal with patients? Well, in the past, a lot of research, and still a lot of research is being done using the electrical activation of the heart. And that's very logical and super relevant. If you don't have a delay in electrical activation, it doesn't make sense to implant a pacemaker to restore that delay because it's not present. So that's logical to understand. And by reducing the delay in the left ventricle, we also expect that the pump function improves. But in between the electrical activation and the pump function, there is the mechanics of the tissue at the regional level that I showed you before. So I think in the normal heart, where the strain patterns in the left ventricle here should look like this, we know that in the left bundle branch block case, it looks completely different. So this behavior is due to the electrical delay. But it's not only the delay that determines the differences in mechanical behavior at the local level. It might be, for example, that a patient, and many of the heart failure patients do have scar, that this wall has scar as well. Not only it's delayed, but it's also scarred. And that does affect the mechanics as well. So well, not only me, but quite a few people hypothesized that the addition of local mechanical measurements in terms of strain patterns to the local electrical activation is really a good combination to say something about how the heart is functioning and how good or bad the heart is in a left bundle branch block patient that fulfills the guideline criteria of CRT. So since we know that the model can reproduce the mechanical consequences of left bundle branch block, we thought, well, let's see how underlying non-electrical substrates like failure in reduced contractility or stiffness, fibrosis, how this affects the mechanics in a left bundle branch block heart. And at the same moment, and this happened while I was actually in Bordeaux, a group of researchers from Utrecht came to us and said, well, we measured septal deformation, and here you recognize this typical septal pattern with multiple peaks again of a left bundle branch block patient, but they said we do not only see this, we also see a pattern like this, which is different, and a pattern like this. And in normal hearts, you expect the septum to behave like this. This is a classical normal behavior, which is also reproduced by our model. So we knew already at that point that simply by delaying this wall, the left ventricular free wall, we could indeed reproduce this multiple peak pattern, which is classically seen in left bundle branch blocks patients. And remember that the previous data I showed you were from dogs, and those dogs were healthy. They did have a left bundle branch block, but the myocardium was healthy. It was not a heart failure dog. So the question of these researchers was that, can we explain in those 132 heart failure patients why some patients show a pattern like that and some patients a pattern like this and that? Because we think that this is of diagnostic value, and I'll come back to that later, because this is the only information they gave to us at that point. So then we started hypothesizing, well, of course, heart failure patients have also diminished contractile function of the myocardium. So what would happen if we decrease contractility in either wall, either in the septum or in the left ventricular free wall, or both? And then we found that if you reduce septal contractility, and we start from the starting situation with the 60 milliseconds delay, so the left bundle branch block, we do not change. Then we see that the mechanical behavior of this septum starts to look like what we can observe in some of those patients. So in fact, this means that there is presence of a left bundle branch block, but that we already knew based on the ECG. But it also says something about the relative strength of the septum compared to the LV free wall. Taking into account the data from the dogs with chronic left bundle branch block, where it showed, and I didn't tell that, but in Maastricht, they also did a chronic measurements in dogs, and then they showed that the left ventricular free wall starts hypertrophying, whereas the septum starts shrinking. And this may exactly be the case in this simulation, where you weaken one wall relative to the other, and then you see this mechanical behavior of the septum changing. Okay, so if we then add failure, contractile failure of the LV free wall to a similar degree, we see that this pattern changes to, again, a very different behavior that very much looks like this. So at that point, we realized that, first of all, these signals can tell you quite a lot about what is wrong or what is not wrong with the myocardium. And second, we have a tool, a model, that can actually describe these complex interactions. So we could also use that model to design a diagnostic index that may help us to predict outcome after CRT. Okay, so later on, the Utrecht group revealed to us that indeed the outcome in terms of reverse remodeling after 6 months of CRT declines if you go from this double peak pattern to a late peak pattern. And that's clinically very relevant. And based on the simulation suggestions that our model provided, we can actually understand that, because the more you go to the right, the more failure of the myocardium you have to introduce. So with that knowledge, we tried to do a very stupid thing, actually, and that is to try to see if we can capture all this complex physiology in one number. And why do we want to do that? Well, because this is what the clinic needs. You need a number to make decisions, either or not to implant a CRT device. So retrospectively, we came up with this number, which is also based on work that had been done before in Utrecht already. And we come up with a systolic stretch index that, according to our modeling work, should be the ideal index to predict, based on a baseline echo before implantation, what is going to happen with this heart if we start applying CRT. And why is this index so good? Or why do we think it is so good? That's because if you have a lot of rebound stretch here and pre-stretch of the late activated wall, that means several things. That means there is left bundle branch block. Well, that's not really the added value of this method, because everyone would use an ECG for that. But it also means that this wall is not too stiff. It's not scarred, because scar is very hard to stretch. So you rule out the presence of scar in the late activated region. And why is that late activated region so important? Well, it's so important because of the Frank-Starling mechanism in that wall, it actually compensates for the loss of work of the septum. So this is a very important condition to fulfill. So the same thing, because this wall is being stretched, the septum, a bit later, it means that the lateral wall is strong, and it means that the septum can also not be too stiff. So altogether, this gives one number that helps you to check whether the desired conditions in the heart are present from which you could expect a good response to CRT. Well, this was studied in a blinded way. We got access to the strain patterns of quite a well-known CRT trial. It's the adaptive CRT trial. So there I analyzed of all those patients the strain patterns, and I quantified the SSI, and we reported that back to the researchers at Medtronic, who actually had the outcome data. And there we could see that, especially in the patients with a lower indication for CRT, so that means a grade 2, class 2 indication for CRT. So those are clinically the most challenging. There you could see those with a high SSI in blue do much better after CRT. So this is heart failure, hospitalization, and death, compared to those with a low SSI at baseline. And also in heart and clinical endpoint of survival, this was the case. So for us, this was a confirmation that indeed taking into account this mechanical physiology makes sense. So I also...
Joost, I have a small question. The black bars, that's the class 1 patients, or?
Yes.
Okay.
So this is the people with confirmed LBB morphology, according to the guidelines.
Those who would implant anyway.
Yeah. You wouldn't doubt, huh? And a QRS above 150. And this is based on the American guidelines at that time, because we were collaborating with an American group. Huh?
Yeah.
I think the European guidelines were slightly different, but I'm not an expert on that. You probably know, Mark. And
Well,
now
it's
they
quite
changed
similar. It's
again.
only that the European heart failure guidelines, they want to use 130.
Yeah.
But for the rest, they're quite similar.
You mean 130 for the class 1 indication?
But for the class 2 also.
Yeah. So this lower number here
Yeah.
should be, yeah, indeed. Okay. So this is, to me, an example where a model can be used to better understand the diagnostic data that we have at hand in the cardiology clinic, and even maybe use that knowledge to better judge which patient is going to do well and which isn't. So one thing I want to add to this is, if there is no reverse remodeling of the heart, and we have a lot of discussion about this here in Maastricht, that doesn't mean the patient is not a responder and that the patient is a non-responder. Huh? Even stopping the progressive disease process could be considered a positive outcome. Huh? So when you are going to judge clinical trials, CRT trials from the past, it always says responders are those who reverse remodel the left ventricle from a very big dilated heart to a much smaller heart. But some patients the disease process may have been stopped, and that's very beneficial for those patients too. Huh? Okay, so talking a little bit about modeling, this we call a forward application of a model. So the model describes the generic patient, and I manually change some of its properties to see how the signals that we can measure in the clinic change, such that we can better understand how to interpret those signals. Can be strain patterns, can also be pressure or flow patterns with this model. That's a forward approach. But what we are investing most of our time at the moment is the other way around, actually, is that we feed the model here with the individual patient's data. And that can be all kinds of data, mostly ECG and functional imaging data in our case. But you can also apply this concept to EP models, which are a lot used in Bordeaux, for example. So we then try to personalize the model such that it mimics at the best possible way the individual patient's phenotype measurements, and using that to actually identify and quantify disease substrates. Basically what we have done in this study with the Utrecht group, but then at a patient-specific level, and maybe even use that information for therapeutic support or prognostic support. Well, this is a future concept, huh? But we're getting very close, and I want to illustrate to you how that works. So if we now take a given set of strain patterns, and these are strain patterns really measured in a patient, and they're measurements of basal lateral wall strain, mid-ventricular strain, and apical strain in the left ventricular free wall. And I on purposely simplify the process. I do not show strain patterns of the rest because it's about the concept. So we also know that we have a model that can actually reproduce this just by changing the properties locally. So that is what we called the forward approach. You change contractility, for example, in the basal segment, you reduce it. Oh, sorry. You reduce it, and then you see that the simulated strain pattern starts to act completely different. It's being stretched because it's, in a way, it's ischemic. It's low in contractility. And you also get this typical post-systolic shortening in the weak segment. But what is also funny is that if you only change the contractility of this piece of the left ventricle, if we go back, you also see that the normal tissue, where we didn't change contractility, starts to act differently. And that, again, is a similar example to what I've shown before. And that's because its mechanical environment has changed. Its preload, its afterload, and so on. So this complexity is very well described by the model. If we now also allow the contractility and the stiffness to change, and in all three segments, we can find a parameter combination that very much reproduces these specific strain patterns. And this is what we called automatic parameter estimation, using an algorithm that is just fed by the clinical data and then returns the most likely parameters at a regional level. So in that way, a cardiologist could measure these regional strains, but also get a prediction of what is wrong or what is not wrong at a local level with the tissue. And this whole process is parameter estimation is a science apart, and that really is a lot of work before you have a pipeline that can do that. And my student Nick van Osta spent 4 years on this and wrote a very nice PhD thesis where he also quantifies how certain or uncertain certain predictions are. So uncertainty prediction is very important here. But that's a very technical story. So if you are able to reproduce this behavior and you know that the solution you get in terms of tissue properties is a unique solution, then we can call that a so-called digital twin. It's a virtual representation, best a copy of the individual patient's heart. And I want to show you 2 cases, really patient cases, where we apply this methodology. And this is really work in progress. So we have done about 10 cases at the moment, and we're extending this to 50, about 100 patients, to see if we can find patterns of underlying tissue properties that much better predict what is going to happen in the future with those patients. But just as an example, this is not a heart failure patient. It's also not a left bundle branch block patient, but this is a 51-year-old lady who was brought in the hospital in Utrecht. And those are measurements from Fedo Kirkels, another PhD student of mine. And this lady came in with a myocardial infarction and was revascularized in the hospital. And you see it's a narrow QRS, it's a normal ejection fraction, and you see that a day after revascularization, you see clear abnormal mechanical behavior. So these are the 18 segments of the heart. You see here which ones. So this is those are the 3 views through the heart, all longitudinal strains. So we cover the entire heart. This is the base, the midventricular ring, and the apex. We have the inferior and anterior wall here, lateral, posterolateral, and this is the septum. So the baseline circuit model, with no differences in mechanical properties in all those segments, of course shows similar strain patterns in all segments. But then we ask the model, using the pipeline that we developed in the past 5 years, we ask to find the closest match to this patient's measurements and tell us how stiff or non-contractile or delayed the myocardium is at the local level. And the best match that the algorithm could generate is this one. So if you look at the similarity between the simulated and the measured strain patterns, this comes very close. It gets very close to the real behavior. And of course, there might be noise on these measurements. And that's tricky, because if we're fitting noise, then that gives a very large uncertainty to the predictions. But so far, we just assume that this is real. And our model in this patient can pretty well reproduce this. It's not perfect, but it's much better than we expected, actually. Also, looking at what the model tells us about the contractile function at a regional level, you see that half of the heart here is clearly compromised in its contractility. Okay, unfortunately, there were no LGE measurements done at this moment, so we couldn't really do something there, but the same patient was brought back in 6 months later. And then the mechanical behavior looked different. You see now that some strain patterns normalized and some were clearly abnormal. So this is a typical scar or ischemic region. I think it's pretty scarred, but it's being stretched. It doesn't contract during the ejection phase, and you get post-systolic shortening after the ejection phase. Here as well, and here as well. And it was mostly in the apical segments. Here you see the LGE data of this patient. Well, if we asked our model to reproduce those 6 months follow-up data, it clearly indicated that there is compromised contractility in the apical segments, which matches quite well with these LGE measurements. So we have done this case more or less as a sort of quality check. If our model would not predict any abnormalities in those segments where we know there is LGE, then we have something to explain. Then it's a bit doubtful what the model is doing. So far, so good. So then we went to a more complex patient. So this is a heart failure patient with left bundle branch block, so a candidate for CRT. We knew that there was no clear LGE, a slightly little bit here, but that is non-significant, not transmural for sure. So we asked the model to reproduce these strain patterns again, and again, it gets quite close. And the model tells us that the latest activation is in these segments here, which is what you expect with left bundle branch block. So there is more or less a septal to lateral wall activation predicted by the model from the mechanics. You also see some blue segments in the early activated region, but the methodology certainly is not perfect yet. Also, what we see is a more diffuse reduction in contractility, which is what you expect in a heart failure patient without clear scar. So that nicely fits the phenotype of the patient. So in this way, well, this is another example of a patient with myocardial scar and left bundle branch block. And there again, the most compromised segments are predicted to be in the apex here. And that's exactly where we knew there was LGE. Those LGE measurements obviously are not, the model is blinded to this. So in a nutshell, this is just 3 cases, but you see how powerful this model can be. And we really are talking to imaging companies like Philips and GE, maybe how to, give this technology some role in the diagnostic devices like echo devices. So, well, how to summarize this patient-specific simulation part, and I don't know if there are any Pink Floyd fans in the audience. I am, but you may recognize this slide because it's inspired by one of their albums. It's The Dark Side of the Moon, where I think we can actually enter heart failure diagnostics in our model and let our model, differentiate between the different myocardial or any other problems that are present in the individual patient's heart. Well, this is our salesman's pitch of our technology, but I think the examples I showed you at least show the potential. The funny thing is that if you create this digital twin, you can also let this digital twin do exercise, or you can actually apply CRT in silico and see what happens. That's a field of research we are exploring at the moment. Okay, so this is what we call inverse application of the model, and then really the integration of diagnostic data in a personalized biophysical model can expose maybe hidden disease substrates that would remain concealed otherwise. So this is how we are currently applying the model. So this is a moment in my lecture. I'm talking for an hour now. I don't know. It's quite a lot of information, I think. I have more to talk about, but maybe at this point there's questions from your side.
Do you have any questions?